Welcome back. We're going to begin the second panel. It's going to be facilitated by Dr. Greg Payne, and I know Dr. Payne will introduce his own his panelists, and I think he has a few comments to make. Thank you, Dr. Payne.
Thank you. Good morning, everyone. Glad you could join us. Mary Lowe, thank you for being the driving force here for the foundation and the meeting today. Thank you so much. I'm a principal at MITRE. I work with Mary Lowe. That's really why I'm here, and I'm also a former Chief Policy and Planning Officer at the VA. We have a distinguished panel here, and our subject is research. You know, what a great topic. I think, you know, what's out there, what's the leading edge, where do we need to go, and how do we get existing findings into practice and disseminated out in the country to those who need it. There's always a little regional variation. There's always gaps getting things into practice. And I've talked briefly with our three distinguished panelists, and I think they're going to cover some interesting things about complementary and alternative medicine, about you know, preparedness and responses to stress in general, and I think you'll find it fascinating. So I'm going to introduce them real quickly. Right now, we're going to start out with Dr. Meyer, but I just want to say a word or two about them, but the summaries in the program. But we're lucky to have Dr. Brian Meyer. He's Assistant Interim Associate Chief in Mental Health at the McGuire VA and expert on PTSD, and we're delighted to have him, also an Associate Professor at Virginia Commonwealth, VCU. How are they doing in the tournament? I don't know, I have to check on VCU in the tournament.
Lost badly.
Lost the first round, sorry about that. And then Dr. Joshua Morgenstein is captain in the U.S. Public Health Service, Associate Professor in Psychiatry at USIS. Some fascinating experience he's going to bring. And then, of course, needs no introduction, but Lieutenant General retired Eric Shoemaker, you know, former Army Surgeon General and commanding general of the U.S. Army Medical Command, currently professor at USIS, all going to offer some terrific insights. So we're going to go start with Dr. Meyer, Dr. Morgenstein, and then Dr. Shoemaker, and then we'll have hopefully time for discussion and interaction. So thank you all for attending, and Dr. Meyer.
Okay, are we able to? I don't know whether we'll get the slides up. I had one of those anti-tech moments this morning when apparently my thumb drive fell out of my pocket on my way here. And I can do this anyway because I can talk for a long time about the subject of integrative health. So let me just talk about why we talk about substance use, PTSD, TBI, and we start talking about integrative health measures. First of all, we need to think about the prominence of these. And what you can see very clearly is that the overlap between at least PTSD and chronic pain is about 66 to 80% in our veterans, which is a pretty astonishing figure. When you start to add traumatic brain injuries, there's about a 40% overlap with post-traumatic stress. There is about a 45% overlap. When we talk about substance use, we start seeing these things over and over again. Just PTSD and pain alone, we're talking about 4 to 6 million veterans. And we don't have a single treatment for them. Which is pretty worrisome. And so I just want to talk about the work that I've been doing over the last 7 or 8 years about this and trying to do what we think about as the cutting edge. So what you can see here is that post-traumatic stress and pain share common regions of the brain. And the most important, for the sake of what we'll talk about here, is a couple of things. One is that you have two of the same organ in your brain, one on the left side and one on the right. It's called your amygdala. It's your alarm system. It's where you have fight, flight, freeze responses. And it is activated highly in post-traumatic stress. In fact, it's kind of stuck in the on position. The same thing is actually true of pain. It's stuck in the on position because pain creates a level of threat. I was talking with one of my veterans yesterday in one of my groups, and he said, "You don't understand. My pain is so bad that I literally cannot think about anything else." And so what does he do? I mean, he has PTSD, so now he's doubly activated in his amygdala. And what does he do? He drinks. And he drinks because that's the way he can calm down his amygdala. And then we talk about what other ways there are to do things. The other area of the brain that's really important here is what we call your prefrontal cortex. It's the area behind your forehead. And the prefrontal cortex is where you do all your logic, your reasoning, your thinking. And the thing is that the prefrontal cortex, in the face of post-traumatic stress and in the face of pain, deactivates. So you're not using it very much, and instead you're subject to emotional reasoning. So what happens when these areas of the brain get activated is then we start seeing behaviors that overlap with each other. And that's what's so fascinating, is that you can have a person with post-traumatic stress and you can have a person with chronic pain, and they will in some ways act very much like each other because of the way their brains are being affected. They will tend to isolate themselves. They will, we heard about the hermit crab. I always think about this as the turtle. You know, they go into their turtle mode and they hide. They stay in man caves, they stay in rooms where they don't have to be involved with other people. But they also get a lot of other things that come along with it. Anxiety and depression and reactivity. A whole lot of different things happen behaviorally. And so it seems like we ought to be able to create a treatment that could address both of them at the same time. And that's where my work started. So the work started really with mindfulness meditation. And mindfulness meditation is something that is very trendy. A lot of what is trendy and what you hear is not what mindfulness meditation is. It is not positive psychology. It is not performance psychology. Mindfulness meditation is very simply paying attention to the present moment intentionally, on purpose, without judging it. And that's all it is. It's very simple. So we will have you focus on your breathing, or we will have you focus on one small aspect. So I'll give you an example of it that you can try right now very quickly. So what I'd like you to do for just a moment is pay attention to the way your seat feels, your rear end on your chair. If I wait a while, your minds will start to drift, and you'll start thinking about all the other things you have to do, because it's the nature of mind to drift. And in mindfulness meditation, we have you bring it back over and over and over again. And if we had time, I would have a conversation with you all about what it feels like. But what you did is you focused intentionally on something that probably you were not focusing on before you came into this room. You probably weren't thinking about what your rear end feels like on your seat. So what do we know about mindfulness meditation? We know, in fact, that it's very helpful with post-traumatic stress. The data has been coming out since about 2012, and we've been seeing more and more data that shows that it's effective in dealing with post-traumatic stress. And I started doing my own work around the same time. The other piece of it, which is really fascinating, which comes out of the work of King and his colleagues, is when we look at what we call evidence-based treatments for post-traumatic stress, they have a certain path from the prefrontal cortex over to the amygdala, where the prefrontal cortex basically learns to override the amygdala. That is not what happens in mindfulness meditation. In mindfulness meditation, there's a very circuitous route, and the amygdala calms down because we get people moving into their parasympathetic nervous systems. So I created a manual. Why? Because there is no manual for mindfulness meditation. And you cannot disperse something as a treatment unless you have some version of it on paper. So I created a 12-session manual. You can see these are the 12 sessions. Interestingly, one of the sessions, which is number 7, Mindfulness of the Body, is really aimed directly at pain. Because back in 2012, when I was starting this work, I thought, okay, I got to do something about pain, but that's not really what I'm trying to do. Well, this became really wild, and all sorts of people really wanted it, and I decided I'd try it over telehealth. That sounded like a really interesting idea because telehealth was really hot at the time. And so I thought, what would happen if you actually tried to do a mindfulness meditation group via telehealth? And so I did a study. And so the first piece of it, you can see the result, a part of it here. And what you can see basically is that there is no difference in satisfaction between, that is statistically significant, there's no difference in satisfaction between the participants in telehealth and the participants who took it in person, which was a shocking finding to me. I really thought that the people who were doing it via telehealth were going to say, no, we can't do it. I had a dozen people sitting in a room, and they were all in Fredericksburg, and I was in Richmond, and there they were going along with it, and they liked it just as well. So then what we did is we looked at what happened with post-traumatic stress, because that was basically the aim of it. And basically what you can find, we used the best assessment for PTSD we have, which is the clinician-assisted PTSD scale. And we found that there were actually significant differences in their results on the CAPS, meaning that their post-traumatic stress got better, and it got better regardless of condition. That really kind of put me out into thinking about what can we do that is really cutting edge, because there's nothing else that has ever said telehealth is really just as good as integrative health as it is in person. So then I started thinking, oh yeah, this is what happens, dogs do it too. Then we started thinking about yoga, because we know, basically, that yoga is effective for PTSD. These are a bunch of studies, they're randomized controlled trials, and they show that yoga really helps with PTSD. And by the way, yoga, in a lot of ways, is mindfulness meditation plus movement. It's doing mindfulness meditation with movement as part of it. And I've talked to lots of yoga teachers, and they all agree with that. So hopefully that works as a definition. And we find that it's effective for PTSD. Well, guess what? It is also effective for chronic pain. And there are studies with veterans in there. And so it didn't seem to me to be a great leap to say, well, what if we did yoga for people with both? We're talking about the same brain areas. And so my colleague, Sue Chopin, and I did this. And she is the yoga expert and yoga teacher, and I just sort of worked around the edges. And we developed something called Yoga for Warriors, which is a 10-session treatment using yoga for veterans with PTSD and chronic pain. And it has been features on CBS, which is kind of fun. There's a YouTube segment on it. You can see, in fact, that it's in the Army. In fact, mindfulness meditation is in the Marines in the form of mental mind fitness training. It's really been adapted by the military, these integrated health approaches. This is what we found. People were very satisfied with it. Again, people like it. And by the way, these were groups that were done with men and women together, which is a little unusual for some yoga groups. And yet we found that there was no problem with that for most people. The only group that there was an exception, by the way, was women who had military sexual trauma. And they did not like being in groups with men. We did find that out. But we found that we had moderate effect sizes for anger, we had it for anxiety, we had people who were much more able to participate in their social roles. We found out that with respect to kinesiophobia, which is basically the fear of movement, which is something that happens, that people develop who have chronic pain, they don't want to move, they freeze, because if they move, it hurts. And what we found is we could drop their kinesiophobia, and we also found out we could drop their PTSD. Again, same kind, do an intervention that affects the same areas of the brain, and you can take care of both problems at the same time. So this led to the final one I want to show you. Dogs do it too, yeah. Which is something called Mission Thrive. And this is the one that is in active development right now. I did it with a team of colleagues. Whoops. Basically, Mission Thrive. What happened was I said, look, there are a lot of smart people where I work. Nobody has figured out how to crack this nut entirely of PTSD and chronic pain. Why don't we? And I gathered a team of 6 other people, and we put our heads together and designed what is a 3-phase, 22-session treatment for combined post-traumatic stress and chronic pain. The first phase is really about learning to manage the symptoms that we get from post-traumatic stress and chronic pain. And so we teach them a lot of different things. We teach them some mindfulness meditation to do it. We teach them some yoga to do it. We teach them some cognitive behavioral therapy. We give them tools to manage the symptom arousal, which is so great for them. In the second phase, we decided to focus on something that has never been focused on. We're so focused on symptom reduction as a field. Let's reduce the symptoms of PTSD. Let's reduce the symptoms of chronic pain, that we forget how radically different this makes people's identity and how radically it changes their roles with other people. When you isolate and withdraw, when you're irritable all the time, when you jump on people if they come up from behind you, it really messes up your relationships in a big way. And so we decided we were actually going to focus. So the second phase is really all about that. It's about how people look at themselves and how they've changed as a result of these things, and how can we rebuild that sense of identity. And then it looks at social roles, and how do you change people's social roles along the way. And then the third phase is what we call thriving, and that's why it's called Mission Thrive. And the idea is basically how can people cope and thrive, not survive, but thrive, even when they have post-traumatic stress and chronic pain. And there are really two answers to that. One answer is you shrink the amount of PTSD and pain arousal, and the other is you grow the rest of their lives around them, so that relatively speaking, what is left is much, much smaller. And that's what we do in phase 3. So Mission Thrive, the theory of it is basically we're going to take the only 3 approaches we know that have had an effect on PTSD or pain independently. And one of them is cognitive behavioral therapy, a second is mindfulness meditation, and the third is yoga. And so we have created an integrated treatment that uses all 3 of those. And basically what we're doing is we're trying to teach people that there is a balance at some point between acceptance and change. You know, it's very much like the serenity prayer, although I often think of it as the wisdom prayer. God, give me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. The wisdom to know the difference. And a lot of what we're trying to do is work on that wisdom part, because a lot of people think, I've accepted my condition and it'll never get better. That's not using the wisdom, because in fact it can get much, much better, even when you have both of these painful conditions. This is my team that I've worked with, and thanks to all of them. The current status of it is that this summer we're going to be undergoing the first pilot trial of it. So stay tuned on it. And if you wish to reach me, that is my email address, and you're welcome to contact me, or I'll be around all day, and I'm happy to talk with you. Thank you.
Good morning. It's nice to be here with you today. Thankful to the foundation for creating a venue to have conversations about such important topics. My name is Joshua Morgenstein. I'm from the Uniformed Services University, and my primary role is as the assistant director for the Center for the Study of Traumatic Stress. My usual disclaimer, get out of jail free because I don't look good in orange, I've been told. So, I'm going to start briefly with an overview of our center to kind of contextualize what I'm going to talk with you about today. I'm going to focus a bit more on the idea of disasters and the mental health effects of disasters. And I think in so doing, my hope is that in addition to some of the areas that have been talked about today regarding psychiatric disorders, traumatic brain injury, substance use, to extend and broaden our thinking and understanding about the effects that trauma, both individual and mass trauma, can have on individuals. So our center was established in 1987 by the Department of Defense, and our initial mandate was to better understand, quantify and prepare for the psychological and behavioral effects of the use and threat of use of weapons of mass destruction. And over time, we have really evolved to studying trauma in the context of disasters. And these are both human-generated as well as natural disaster events. Some of our earliest work that our scientists were engaged in involved support following the U.S. Military plane crash in 1985 in Gander, Newfoundland. I see some heads nodding, so I think some folks are aware of this. This event was really the most deadly loss of life in peacetime that's ever occurred in a military air crash. And our center scientists were engaged in supporting the families at Fort Campbell, Kentucky that were involved, as well as the leaders there. In addition, it began some of our work supporting often forgotten populations at Dover Air Force Base. We spent a great deal of time beginning the process of what would become decades of trying to better understand the impact on mortuary affairs workers and others who are exposed to death, dying, and human remains. And when I talk about disasters, I like to kind of quantify and help people understand exactly what I'm talking about here. For those who are in a policy lane or who work in government positions, the idea of a disaster often involves a declaration. They may think about the Stafford Act and criteria requirements that essentially involve a situation where needs outstrip resources. There's a lot of legal implications that involve access to resources and things of that nature. So for instance, major hurricanes and wildfires that we've experienced just in the past 6 months in the United States would sort of qualify under those ideas as a disaster. This is a depiction of the range of disasters when we study disasters from a psychological and behavioral health perspective. Why are these all here? Because some of these things, mass violence episodes, acts of terrorism, a mass shooting, wouldn't necessarily result in a disaster declaration per se. But what we found after decades of studying this range of events, these type of disaster events or mass trauma events, is that they produce a predictable and well-established range of adverse psychological and behavioral responses. And so this range of disaster events has become important for us to sort of think about from a psychological and behavioral health perspective. And just a few numbers. I think many of you may already be aware of this, but from an extreme weather perspective, these types of events, this is information from the Center on the Research on Epidemiology of Disasters. It's an international organization that's relatively well respected for its ability to quantify data. But it demonstrates a relatively noteworthy trend in the increase in both frequency and the financial costs associated with some of these events. If we look here in the United States, the Federal Bureau of Investigations, this is information on the rate of active shooter events over the past 17 or 18 years. And again, both of these slides, I hope what they demonstrate primarily is that we have been seeing an increase in need for understanding preparedness, response, recovery, interventions, et cetera, for the psychological and behavioral effects of mass trauma events. So I'm going to transition now to sort of talking about what are the effects on individuals and communities? What are the behavioral and psychological effects that we see? I think one of the things that we often think about are a very important area, and those have to do with psychiatric disorders. So anxiety, PTSD, depression are all things that happen and phenomena that cause significant morbidity and mortality after disaster events, and our literature has shown that. I think some of the things we think a little bit less about are things like health risk behaviors. Increasing use of alcohol and tobacco as a way of medicating distressing feelings or emotions related to a disaster. People who throw themselves into their work to the exclusion of their own well-being or perhaps the ability to care for their own families. And other types of phenomena that represent additional public health burden. And perhaps most important of all are things that we have identified as distress reactions. So insomnia, avoidance, scapegoating, and another important one, a decrease in perceptions of safety. All of these tend to lead to various types of behaviors for individuals and confer significant risk down the road. And part of the process of better understanding these types of phenomena has been to help us reconsider altering the trajectory of recovery for individuals. So notionally, rather than waiting for people to develop a psychiatric disorder, which for some of these conditions takes up to 30 days after an event occurs, things like insomnia and feeling unsafe and drinking more tend to happen right away. So the first night after a disaster. Almost half the US population indicated after 9/11 that their sleep was disrupted for the first 2 weeks after that event. That is an incredible public health burden, incredible. And knowing that these types of distress reactions, health risk behaviors, in addition to psychiatric disorders, are things that occur in the wake of a disaster, helps us more effectively understand who needs to be at the table to be thinking about how we address these things early and often so that we can alter in a positive way the trajectory of recovery. This isn't something that psychiatrists or family physicians like myself are going to be able to manage by ourselves. There are a lot of other people that need to come to the table and that need to be part of conversations about that. And of course, lest I leave you with a doom and gloom notion here, the vast majority of individuals exposed to disaster events or mass trauma will manifest with resilience, meaning that they will resume their normal functioning and go on about their lives. And in fact, there are some people who will manifest what has sometimes been termed as post-traumatic growth, in that they will feel an increased sense of their ability to rely on their own self and their own capabilities in managing future trauma or future adverse events. I also want to show this slide here because this is a relatively well-established sequence of events or phases through which communities tend to progress following events that involve large community disasters. So understanding that there are things like a honeymoon phase, a disillusionment period, and anniversary reactions is critical for people involved in the management of disaster at all levels, whether that's families or healthcare providers, community leaders and policymakers, to understand that communities will evolve through these phases and that certain communities are receptive to certain things at certain times, and the ability to resource things properly becomes critical in terms of where you put people, resource people and things to optimally manage and respond to a community with the goal of improving their well-being, decreasing their distress, and increasing people's functioning. There's also folks that we know are particularly vulnerable to disasters, and a number of factors that tend to come into bear. And there are things in the pre-disaster time period, so things that people bring with them to a disaster that confer increased vulnerability. There are aspects of disaster events themselves, as well as post-disaster recovery events that may transpire, and people may have one or more of these types of vulnerabilities. What we've come to believe and to find is that the better we plan and prepare for these things, the more effectively certain special populations or populations at increased vulnerability are able to navigate and recover. So in the pre-event time period, things like some of the things that are listed here, but mental health conditions, so people with particularly active pre-existing mental health conditions or substance use conditions are at increased vulnerability for relapse, a loss of ability to rely on services that may be disrupted and things like that. Various event impacts that I mentioned and recovery factors that can occur for people. All of these things can add up and combine to create a particularly potent network of stressors for people who are navigating through as an individual or part of a community following a disaster event. Now I'm going to talk to you briefly about the scope of disaster events, particularly the psychological and behavioral effects of disaster events. Jim Schultz and his colleagues, I couldn't have drawn this better, but I think the take home here is clear, and that is that what we have discovered over time is that the psychological impact of disasters vastly exceeds all medical impacts combined. Not just in the sheer numbers of people that are affected psychologically by a disaster with distress reactions, health risk behaviors, or psychiatric disorders, but the geographic distribution of people who are affected. much further than the geography of the disaster event itself, and the time course and the trajectory. Psychological effects tend to be things that people put aside when they're dealing with more acute issues for themselves, like where am I going to get food and shelter? How am I going to take care of my family? It's easy to put off one's mental well-being. So it can be weeks and months down the road before people even acknowledge or are able to think about, feel able to think about these things. And of course, they tend to last for longer periods of time. The longer they go unaddressed, the longer they tend to last. So in thinking about this, why is this the case? Well, we have different populations that are exposed to these events. We have direct victims. We have families of survivors. We have first responders and public health emergency workers, which is another population that we've studied. I'll talk to you about that shortly. And then we have wider communities. So the rings, the outward expression of the experience of a disaster is broad. We also know that media plays a pretty significant role in the transmission of exposure to disaster-related events. A number of research studies have demonstrated connections with increased exposure to media, particularly television over time, although a lot of research is going into looking at social media and its impacts. But what we have found is that increased exposure to media tends to bring worse outcomes for people. So there's a point at which exposing ourselves to media generates information that helps us decide what to do and makes us more effective. But beyond that, what we tend to be doing is kind of inundating ourselves with excessive amounts of exposure. And that increases risk because the severity and the duration of exposure to trauma, even visual trauma, increases people's risk for developing things like distress reactions and health risk behaviors in particular. I think most folks are familiar with Hurricane Katrina and the impact that it had. This is what's been called the Katrina diaspora. And these are, this image depicts locations from which about 1.5 million displaced people applied for government relocation services. In other words, I've had to move from this area because of the effects of this disaster, and I need to resettle somewhere. Please help me financially. I think what this conveys, if nothing else, is that disasters, in addition to being local events, are not merely local events. They affect much broader communities. The folks who are affected here lost jobs, homes, social support systems, perhaps spent time, varying amounts of time in relocation or evacuation centers, which bring with them their own sense of distress and anxiety, and a number of other hardships that increase their burden and their network of stressors and the burden of stress and distress for them. So what do we do for folks in the wake of disasters? How do we help people? And hopefully the title makes it clear here. I won't be talking about medications or therapy. So what do we know? In 2007, a landmark article was published in the journal Psychiatry. It reviewed about 3 decades of disaster literature, and this was co-authored by 20 of the world's probably most well-renowned internationally disaster mental health experts. And what they found is that when we look at all of the things that we can do immediately and in the very short kind of midterm to help people after exposure to mass trauma, that there are really 5 essential elements. And those involve enhancing people's sense of safety, helping people to feel calm, increasing a sense of self and community efficacy, optimizing people's social connectedness, and increasing hope and optimism. Those factors tend to predict or portend a better outcome for people. And those 5 essential elements form the framework of what was later called psychological first aid. And psychological first aid right now is the basis for many organizations and entities and programs that are designed to help people in the immediate aftermath of mass trauma and even increasingly individual trauma. So psychological first aid is really designed to be analogous to regular first aid or basic life support. These aren't things that healthcare providers are necessarily intended to do, but communities to do. I think Valerie Cole is here from the Red Cross, so may talk to folks a little bit more about that this afternoon. There are organizations that are helping people to better understand. It's great to be trained in how to use an automated external defibrillator. People seen these? Hospitals or other buildings, your workplace may have them. Airports are all equipped with them. Most of us in our lifetime will not encounter somebody in the middle of an acute coronary syndrome or a cardiac arrest. Almost all of us will encounter people at varying degrees who have experienced varying degrees of trauma. An understanding of how to go about helping people and supporting them in the wake of that can alter the trajectory of people's recovery. So let me tell you briefly about some of the work that we've done at our center. Folks who have lived in the DC area for a long enough or around in the 2002 timeframe will invariably remember. For a 3-week period of time in October of 2002, a young man and an adolescent, drove around killing people. This was the DC sniper shootings. Brought a great deal of fear and distress to the Washington, D.C. area and surrounding states because of the geographic distribution of these events. And what was probably most distressing was when a child was killed. The fear, anxiety, and behavior changes for individuals really ramped up. We've done some of the only work looking at what happened and how our community was affected after this event. We had a relatively robust response rate to our phone sample, and what we found was when we looked at people's perceptions of safety, people who felt less safe did worse. How did they do worse? Well, decreased perception of safety is associated with poor sleep, increase in alcohol use, higher rates of depression, and acute and post-traumatic stress disorder. So feeling unsafe is not good and makes things worse. When we transition to the idea of efficacy, which I mentioned as another one of the essential elements, we looked at a concept called community collective efficacy, which is essentially the willingness of community members to intervene for the common good. It's a measure of community strength, and it's a perception that any individual, any one of us may have. You might be thinking to yourself right now, how strong is my community? If there was a disaster, could I count on my neighbors to help? Would people help me if I needed that? That's a really important thing, as it turns out. We worked with over 2,000 Florida Department of Health workers following a particularly severe hurricane season in 2004. We controlled for a number of significant variables in our studies. We looked at community collective efficacy, depression, PTSD, and other outcomes. And what we found is that higher community efficacy led to lower depression and lower post-traumatic stress disorder. Simply perceiving yourself as being part of a strong community meant that you had a statistically lower rate of depression or PTSD. Even more striking to me was what we found in terms of how community collective efficacy mitigated another element of adverse impact. I don't know if this will project up here, not really. So what you'll see on the top dash line are people with high injury. The solid line is people who sustain low injury or damage. And if we look at the x-axis, this horizontal line, that's people's reported perception of the community collective efficacy. So on the left, down at 1 is, I don't live in a strong community. And at the right, up at 5, that's, I live in a very strong community. On the vertical axis is the probability of having PTSD. So for people way down here at 1, I don't live in a strong community. In general, you can see that the probability of having PTSD was much higher. And not only that, but that injury, as we know, significantly increased the risk for having PTSD. But amazingly, when you move all the way to the right, and we look at people who reported the highest levels of efficacy, not only did their likelihood of PTSD drop dramatically, but the role of injury in increasing the likelihood of PTSD nearly disappears. Strong communities are protective. What do we do about this? Well, we do a lot of things, but at our center, in addition to research, a broad research mandate is education, training, and consultation. One of the things we've used as a tool for helping communities is to identify relevant stakeholders after disasters, and we use just-in-time, customized, easy-to-read, and highly actionable disaster mental health education fact sheets. These are all freely available at our website. They're in the public domain. We have several hundred of them, and they are tailored to a whole, very broad range of issues that have been brought to our attention over many years. So our repository is relatively robust. But educating people and telling people, answering a very critical question after disasters, which is, what do I do, is essential in helping people to begin to respond and recover. And our education fact sheets are designed to answer that question, what do I do, and to help people with those action steps. So where do we go from here? What's next? Well, there are a lot of things that we actually, it would really help us to know more about. For instance, we have a very clear sense that psychological first aid and these essential elements are important in helping people to begin to respond and recover effectively. But which of these elements are most important early? Is it most important to help people feel safe early on, which is probably the case, versus ensuring people have a sense of efficacy as time goes on? Which first? Who should be getting these interventions? Are some of these early essential elements more important for certain populations than other populations? That's not clear right now. But understanding that would help us more effectively and more quickly target those types of interventions to people in need, again with the goal of altering the trajectory of recovery for people who are affected. And expanding our resources. What would it be like if everyone in a community was trained to implement psychological first aid principles? What if every neighbor, friend, coworker, family member knew how to do this, understood this, was taught in schools to people as an essential part of life? People experience trauma, and here's what you do to help. What might that be like, for instance? Those are all questions that we don't have answers to right now, but some of them are being looked into, and others would really help us to more effectively respond to disasters in the future and mitigate these adverse effects, particularly on our most vulnerable populations. My email, and I will pass it on to Dr. Schoonmaker.
So I'm Eric Schoonmaker. I'm, like Josh, a professor at the Uniformed Services University of the Health Sciences. I knew I was going to be the last speaker in a short program, and this is about the time in human physiology where your mind begins to notice your butt on the chair again, in spite of the fact that you're not doing a mindfulness exercise. I also knew that when you share the podium with passionate people, they're going to talk a lot about their work. And so I'm going to tell you that there are only 2 slides that I'm going to have you really focus on in this set that talks to the points that I want to make. The others are supportive of it. This slide here is intended just to show you some scenes that characterize the wars that we currently are in. And I'm one of those folks who doesn't believe there's a signature wound of these wars, but I know there's a signature weapon, and it's right in the center there. It's blast. Blast has done everything that we see happening to people, from psychological injury that you just heard Dr. Morgenstein talk about and Dr. Meyer talk about, to physical injuries, so whether they're amputations or traumatic brain injuries, burns, hearing, eyesight, and like. But these wars are also, as all wars are, characterized by tremendous pressures, as you can see, losses that individuals suffer. And it spawned a recognition that we can apply a group of what I call disruptive technologies, yoga, acupuncture. It just happens that they've been around for about 4,000 years plus. But they're still as disruptive as anything that may be invented in the next decade or so. I have to put this up here too. I have no financial investment in this. I do have to acknowledge that my wife is a yoga instructor. In fact, I'm recovering from her yoga class last night. It's a mixed woman and man class. And she also teaches mindfulness and has a practice in wellness around that. And that these are the opinions, much like Dr. Morgenstein's. These are opinions of our personal opinions and not reflective of either the Department of Defense or the university. A lot of people don't know much about what goes on within the DOD and DOD medicine. Okay, better. So I'm just going to give you a real quick overview of that. DOD is a large vertically integrated healthcare system, meaning that it performs health promotion and health care from cradle to grave for about 9.5 million Americans. Active duty, their families, retirees like me, my family, and anyone who has a medical or combat-related injury while on active duty. If you combine that with what the VA has, about 9.5 million, we constitute a federal health system that is probably the largest in the country. It certainly rivals any other large group out there right now. It's in the top 3, about 10% of the population of the country. We fund and conduct our own, what we call requirements-based research, meaning that unlike, say, the NIH model or most of the university models out there, which are investigator-driven, we also keep in mind what we're trying to solve as the principal problem. And this causes some issues for investigators, but we do pretty good on, I think, in bringing those together. And we direct care either through science or through policy development. We can implement practices as best as possible. And with the VA, we're part of a continuum of healthcare delivery and health promotion that extends from when an individual's on active duty all the way into either retirement or movement out of uniform, even if they don't retire. Our principal focuses then are on implementation and translational science as much as discovery science. If you think about the activities of science, they begin with discovery. You know, those are the things for which Nobel Prizes are awarded. And for that reason, translational and implementation science isn't really very attractive to people. It's kind of the nug work of how do you prove that discovery that we made, or that mindfulness practice, or that drug that was just developed can be applied effectively in a clinical situation and deliver the kind of results that we want. And there are very few, if any, awards given for that kind of thing. Even the manufacturers of devices and drugs don't like to get too involved in that because it's so expensive and so lengthy. A vaccine today takes $1 billion and 10 years to develop. $1 billion and 10 years. We're also focusing, and I'm going to use pain management as an example of this, we're focusing on tackling not only the problem of opioid abuse that you've heard referred to here today, but also the genesis of that. And we'll talk briefly about that. It's one of my principal slides. And we're doing this as a whole of government effort by aligning yourself with other members of the federal medical community, like the Veterans Administration, the NIH, and others. Okay, this is one of those slides. This is a busy slide. Don't get discouraged, but I just want to show you a process, and then we're going to go back and show how this was built. This started for a lot of us around pain management. And by the way, how many Americans of 370 million are in pain in the course of a month from surveys that are done? Anybody have an idea? All of them? Good. I like that answer because quite frankly, I'm up here right now and I've got a little rotator cuff problem from too many downward dogs, and so I'm in pain right now. There are very few people that don't experience pain. But as far as pain that disrupts life, that interferes with what you might want to be doing, even in a minor way, about 100 to 120 million Americans when surveyed, will tell you that they've had pain to that degree over the prior month. And probably 10 million of those have such severe pain that they have a very difficult time conducting anything that resembles a normal life. What I'm going to show you is a timeline. Time goes across from left to right. The groups and working on this are at the top, and the products are on the bottom. And we got involved in this in the Department of Defense and the Army about 10 years ago when we realized that people coming back from combat, or even just training for combat, or our older population, were experiencing lots of pain problems, and we had a real narrow focus on how to treat that pain, largely through devices like spinal cord implants or from drugs. And drugs were starting to get us in trouble. And so I chartered a task force as the Surgeon General, the Pain Management Task Force, in 2009, and I asked them to look at all modalities for treating pain, and they came back to their credit and said, you know what, sir, to be honest with you, there's a lot of stuff out there that works that we're not using, and there's a lot of stuff we're using that frankly doesn't work. What's the most common application or modality that's used to treat chronic pain in the United States today? Medications, especially what? Opioids. How much evidence is there for the use of chronic opioids for chronic pain? Zero. 7% of the global population, the United States, prescribes 95% of all the opioids in the world. And yet there is no evidence for the utility of chronic opioids over maybe 3 months. And in fact, studies now appearing seem to suggest that even short-term pain can be managed as effectively with non-opioid approaches. And yet we've overlooked an enormous number of things that might work. The Institute of Medicine followed the following year with a really landmark study that was reported, or a report, Pain in America, and that really galvanized the whole federal government to look at this. We started working within the DOD, the Army, the Navy, the Air Force on issuing clinical practice guidelines to try to apply these measures in a battlefield or non-battlefield environment. At the same time, this Institute of Medicine, now the National Academy of Medicine, study mobilized the NIH and the Department of Health and Human Services to go back and say, look, we already have a coordinating committee that looks at pain research. Why don't you develop a whole national strategy for the treatment of pain, for the management of pain? And that will come out later as a national pain strategy. In the meantime, I sit on the National Advisory Council for the National Center for Complementary Integrative Health, used to be called the NCAM, or the National Center for Complementary and Alternative Medicine. But those of us who work in this field do not want to build an alternative universe. We want to take these complementary practices, some of which you've heard about here, mindfulness yoga and others, and we want to integrate that into conventional treatments. And we want to use evidence and the individual tailored approach to a patient to find the best way to treat an individual patient's chronic pain. That work in the National Advisory Council for the National Center for Complementary and Integrative Health resulted in their bringing together the VA and the DOD in a common environment and a common research effort to try to demonstrate, using the VA and DOD platforms of care, the utility of these complementary approaches. And that's been very successful. In the meantime, the president got involved. We have a number of directives, and starting at about here, what you'll begin to see is a focus not on pain so much as on opioids, on addiction, on opioid use disorder, on limiting access to opioids. So we've gone from a focus on pain and how we manage pain to a focus on opioids. In fact, many are concerned that this criminalization of opioid use and the limitation of opioids is denying some patients who require opioids access to opioids, when in fact the real problem is pain. Okay, how do we get here? Well, this started off in the battlefields, and you all know this story. We had improvements in battlefield care because of better trained medics and improved equipment. We have incredible medevac capabilities. We all tell people, if you're ever in a motorcycle accident on the highway and you traumatize your leg to the point where you might bleed to death, you might lose that limb, maybe have a head injury with it, where do you want to get treated? You want to get treated in Kandahar, Afghanistan. You're going to get to the facility faster, you're going to get state-of-the-art care, and you're going to have the highest probability of recovery, survival, and then recovery. And this survival and recovery has been really pivotal for us. We've made great advances. In fact, we retained over 300 soldiers in the Army alone with prostheses, sent 45 of them back into combat, not all of whom lost their limb in combat. You've heard about the fact that this is really plaguing veterans as much as it is the active duty. And what you'll notice is most of the pain, chronic pain, which is not a disease of the tissue, it's a disease of the brain. Once pain is established, after a period of anywhere from 6 weeks to 3 months, very different for different people, a process called chronification takes place, and it becomes seated in the brain. And it becomes a dialogue between this amygdala, the limbic system of emotion, the hippocampus, which stores memory and processes memory, and this part of the rational brain that tries to control things. And that's individualized for every individual. Your chronic pain is not the same as yours, is not the same as mine. It's very individualized, almost like a fingerprint. Here's a little chart. Don't worry about the words and everything. Just look at the melody rather than the lyrics. This is over the course of a 10-year period during which we were in active combat of all of the clinic visits and hospitalizations that took place within the DoD by problem. And you'll notice all of these flat lines down here, heart disease, kidney disease, cancer, were pretty flat. But what went up in the outpatient setting and the inpatient setting? Musculoskeletal problems and psychological problems. And this isn't from combat. You saw the picture of the soldier there from the 10th Mountain Division. Average load of a light infantryman is 120 pounds. By the time you're 35 years old as a light infantry soldier or a young Marine, you've got the neck of a 65-year-old and the knees of an 80-year-old. I mean, this is a wear and tear problem for us all. And this is one of the big issues that you heard Dr. Meyer talk about. It's the fact that, and this is a VA study which has been replicated across thousands of patients, that chronic pain rarely exists alone. Chronic pain occurs in our populations intersected with post-traumatic stress disorder or traumatic brain injury or mental health problems. By the time you develop chronic pain, it's a dialogue among and between all of these problems, and you've got to manage all of them if you're going to manage the chronic pain. So this is the second slide I want you to remember. We're often told we have an epidemic of opioid problems in the country. Well, I maintain we don't have an epidemic of opioid problems. We have an epidemic of epidemics. The opioid problem has brought an epidemic of other problems. We have an epidemic of hepatitis C in some communities now. We have an epidemic of bursts of HIV from needle sharing and the like in communities. We have an epidemic of early death. Life expectancy in the United States has been dropping over the last 2 to 3 years. First time in 80 years. Much of it is attributable to the opioid accidental death problem. How many people died in Vietnam in the war in Vietnam? Pardon me? 59,000, thank you. How many people died in these wars, Afghanistan and Iraq? Thank you very much. 7,000, roughly 7,000 people. We've lost more from accidental opioid overdose every year than we lost in the entire Vietnam War, and certainly far more than we've lost in Iraq and Afghanistan. We now lose more people from accidental opioid overdose, either prescription drugs or illegal drugs outside that they get hooked on. In fact, we've got a reverse of what we used to have. We have people going from prescription opioids, frequently given for pain relief, when they run out of a prescription or they can't obtain it illegally or by diversion. How much does OxyContin cost on the street in Washington? It costs about $1 a milligram. So a 20 milligram tablet is 20 bucks, and 200 milligrams is going to cost you 200 bucks. How much does heroin cost on the street? $7. So we have people from the suburbs, from all walks of life, who got hooked on prescription opioids for benign reasons, really. Best illustrated, by the way, in the book Dreamland, if you've not read that book by by Canones, that we have communities across the country in all walks of life, in all sorts of economic groups, becoming addicted or subject to opioid use disorder for prescription drugs, which has taken them into this. So let's think about another epidemic. Here's cholera. This is a cholera epidemic in Africa. We're going to start seeing this in Mozambique and Zimbabwe pretty soon. And what do? We manage the cholera patient with fluid resuscitation, antibiotics eventually. But if we can manage fluid loss, we save their lives. In a like fashion, we take care of people with opioid use disorder or addiction, and we have to come up with inventive ways to make that happen. But there's a very famous story about this man, John Snow. John Snow was an anesthesiologist in London in the 1850s. London was plagued by a series of epidemics of cholera. In 1853, he finally used local clergymen and others to track where patients were coming from who had the cholera, and they all tended to hover around this pump on Broad Street. The upper class, by the way, and the middle class weren't suffering from cholera because they weren't using that pump. They were drinking beer and wine. Beer and wine was a very safe way of getting water. But the poor, the impoverished, those that were trapped in the ghetto in London were using this pump. And when he took the handle off the Broad Street pump, the cholera epidemic ended. This is a slide to illustrate what we need to be doing for this epidemic, which is not focused entirely on taking care of this, but also going back to the root causes. And the root causes are the psychological problems, are the associated comorbidities of pain, and all of the things that lead to this witch's brew of chronic pain that's plaguing us. And we need to use every device that we can. In fact, the Pain Management Task Force that we sponsored and published said we've got to get a patient-focused, holistic, and multidisciplinary way of approaching this, very much like what the Institute of Medicine National Academy said. And this has got to be peopled by a group of treatments, and this is 10 years old. In fact, 10 years ago, all of these were known to be effective. Karen Sherman in the Pacific Northwest did so many yoga studies on the effectiveness of yoga and pain that it's almost not worth doing any more yoga studies. What's wrong is we don't have application science. And the people who populate this building have not passed the laws necessary to get us access to this. My wife, who became a yoga instructor because she had low back pain from being a college athlete, has gotten acupuncture and yoga and guided imagery in a variety of communities. We moved 16 times while I was on active duty. But did our TRICARE health benefit pay for that? No, it doesn't. Does Medicare cover most of the treatments available for chronic pain that are evidence-based? No, it doesn't. CMS, for example, the Centers for Medicare and Medicaid, are hampered by the fact that that evidence hasn't been gathered in such a fashion that it can pass through the CMS filters of over 65. And even if it does, Congress has to pass specific laws that license, that rather enable an acupuncturist or a medical massage therapist to get Medicare and Medicaid funding or reimbursement for their services. That has to come through laws. And so I'm here to tell you that I don't think our problem, and we've coordinated this across the interagency now, I think it's been a very successful effort. I think this could be applied to many other problems that we're facing and we are facing right now, whether it be the problems of the social determinants of post-traumatic stress and post-traumatic stress disorder in communities, or the problems that we suffer from traumatic brain injury, a whole-of-government approach. But it's got to be coupled with policy and implementation of standard practices that can be compensated for. And with that, I'm going to sit down and allow questions. Thank you.
I know the congressman might be coming later, but I've not gotten the high sign, so great job, guys. Questions for our esteemed panel or panelists? Have at 'em.
So how much of the reticence within Congress to take care of addiction-related problems, do you believe is due to the fact that the vast majority of the population who has no experience with addiction believes that it's the addict's fault?
I don't manage addiction therapy. I manage pain.
Right.
And there is no question that there's a wide, and I'll just comment on, you can't get into this problem of comprehensive pain management that, again, people don't drift into talking about opioid use disorder and addiction. There are a lot of misunderstandings and misgivings. I think you probably are privy to now discussions about approaching opioid use disorder and addictions as a disease state and approaching as a public health threat, which is what it is, as opposed to a criminal or a moral problem. It's often confused as a moral problem. And I like to present this in this fashion to kind of promote the fact that we've got a lot of young athletes, we've got a lot of young soldiers, we've got a lot of old soldiers who have become victims of opioid use disorder, in some cases through no fault of their own. You know, it's funny. I give this talk and talks like this all over the country. The last time I took a flight to San Diego, about 6 months ago, I sat next to a lady who, when she found out I was working on this, said, you know, the last flight I took out here, I will live in the D.C. area, but I'm going out to San Diego to visit my mom. The last time I did this was a couple years ago. My mom is 95. She had her hip replaced. When she was sent home, she was given a bottle of OxyContin and told to take them religiously every 6 hours, which she did. She's of that generation that takes the doctor's orders. And when she ran out of that first 300 or whatever it is, she got a refill, she became an addict. And then when we went back to the rehab center and said, hey, my mom's now addicted to this OxyContin, they said, you have a couple choices. You can put her back here in the rehab center, but it's going to be very expensive. You can put her out into a street program for street addicts and pushers in Los Angeles, or San Diego rather, or you can do it cold turkey at home. And so she did it at cold turkey at home. It took about a month to 6 weeks. She says the worst 6 weeks I ever spent with my mom. I had a 93-year-old mom going through cold turkey withdrawal from a drug that you all put her on.
If I can add to that, I do a lot of work with drug courts and veterans treatment courts, and I am asked to go around to talk about the opioid problem, which I think is fascinating because I completely agree with you. I talk about, half my talk is about pain and about alternative and complementary ways of dealing with pain. However, I also talk about something called medication-assisted treatment. And we know from the data that there are two medications that we can give. One is methadone, the other is Suboxone. And if we give those two medications, we know that we can literally save 2/3 of lives. But as I go around the country and I talk with people in different sections of it, I get different responses. So there are some that will say, yeah, this is really great. And I got others who say, well, our sheriffs won't give naloxone, which is a life-saving medication for people who've overdosed. Or I get judges who say, I'm not letting the people in my courtroom do that. And these are people in drug courts and veterans treatment courts. You would think that they're the choir. They are not the choir sometimes. And so we have a huge systemic problem. And I think that part of the answer is what some states have begun to do, which I think is very helpful, which is to say prescriptions for opioids need to be limited to X number of days. Because we now know that for a teenager, it can take as little as 4 days to become addicted because of the developing brain to an opioid pain medication. And adults can take, if they have pre-existing genetic vulnerabilities, as little as 7 days. And the typical prescription is 30. It's no wonder we create this whole problem. And so I come from the state of Virginia, and Virginia has done what I think is a great thing, and they've limited prescriptions to 7 days. which is what you really need for most surgeries, is about 7 days, maybe with one renewal. And if we can, in a legal sense, begin to limit how long prescriptions last, we can cut in back at the pump. It's back at the pump. I love that analogy. Because we're pumping out the opioids. So if we stop it back at the pump, that'll make a big difference.
I don't think there's a way around that. I mean, truth in lending, David Cooper-Smith is my massage therapist, so he'd love knowing that his name is being used in a public forum, by the way. But you're right. I pay for David's services out of pocket because my coverage doesn't extend to medical massage. But I know he's kept me out of a lot of surgeries. He's kept me out of medicines and things like that because I'm one of those old soldiers that did bad things to my body when I was younger. And this is a warning to any millennial in the area: just take care of your body now, so you don't pay for it when you're my age. But you're going to have to engage. I mean, this is personal on my part, but personal advice: you're going to have to engage through lobbying efforts, through groups who can go to the Hill and make it clear that these things have to take place. I don't know any other way around it. One of the biggest blocks we have right now is to remuneration. Now, there are programs out there and large group practices that are beginning to realize this, the Kaisers of the world and Aetnas, when they go back and analyze their data, what they recognize, for example, if you can get a patient into a massage therapist or a chiropractor or a physical therapist, first and foremost, their use of opioids and their risk of becoming an addict to an opioid is markedly reduced. So they're beginning to see the value of these kinds of things. But I think having each of your communities also be very active as the chiropractic community. Why do we have chiropractic care in military hospitals? We have them in all of our military hospitals. Why? Because the chiropractors got engaged 20 years ago, and it's now become one of the available services to us. Ironically, we can't get it outside the gate through our TRICARE health benefit, but we can in our own facilities.